Hey y'all, really excited to be here today. I think most of us have either been on a shift or overlapped with someone in practice or even just chatted with someone over the phone accepting a transfer and been like, oh my gosh, are they a dinosaur? Their practice is prehistoric. That's what I'm going to talk about today. I'm going to talk about prehistoric practice and knowledge translation. What we hope happens, and theoretically what happens, is we have some evidence that supports a practice. And that evidence, hopefully, will reach a patient's bedside, not just in academic and urban centers, but in rural centers and community centers across the United States and across the globe. That effort, translating that evidence into clinical care at the patient's bedside, that is called knowledge translation. But the time that it takes to do so is not instantaneous. It doesn't happen just like that. It's called the knowledge translation gap. And that gap, well, the amount of time that it takes, it can vary. But often what we find is that it's 10 to 17 years between when evidence culminates and says, okay, you should do something or you shouldn't do it, and when that reaches the bedside for most patients seeking care. And that gap, again, it can vary whether it's industry sponsored or how much attention is garnered to that specific disease process. And you may be thinking, I think she's exaggerating just a little bit, but I'm going to share with you an example that I think we encounter on a regular basis, whether it's in the pre-hospital setting, the emergency department, or even the inpatient setting. A patient comes in and this is their rhythm strip. That ain't good. Hopefully at that point, CPR is ongoing. You have a patient in cardiac arrest. Now, what inevitably happens during the course of their resuscitation during the CPR is a pulse check. Somebody says, hey, can you pause for a pulse check? Pulse checks in CPR are kind of ubiquitous. And the idea is that you recognize a pulseless patient in 10 seconds or less. I mean, that seems easy. We all have years of experience in medicine, in clinical medicine, in the textbook medicine. We obviously are very skilled at doing this. Except for when they've studied this, when they've looked at patients who are undergoing coronary artery bypass grafting, and they're either on having their spontaneous circulation or they're on non-pulsatile ECMO, i.e. they don't have a pulse. What they found is only 2% of people could recognize a pulseless patient in 10 seconds. Now, when I read this statistic, I was like, well, obviously I'm the 2%. The problem is I think we all probably think we are in that 2%. It turns out that accuracy is actually pretty abysmal. Overall, accuracy is about 78%, which isn't bad. Specificity is about 55%. They found that 45% of people could not find a pulse in a patient who had both a carotid pulse and a systolic blood pressure of 80 millimeters of mercury or higher. And then 10% of those that had an absent carotid pulse were not identified as having an absent carotid pulse, i.e. someone is feeling their own pulse in their fingertip or something like that. So something that we are trained in, that we do on a regular basis, that happens across the United States in ambulance bays, in the emergency department, in inpatient codes, we are not that good at. Yet we do it. And why is that? Well, because there are these difficulties with pulse assessments, the American Heart Association has actually recommended that interruptions in chest compressions for a pulse check should be minimized during resuscitation, even to determine if ROSC has occurred. So if you're worried, like, hey, maybe this patient, maybe their heart is beating again, maybe we can stop the resuscitation, they're saying that even if you want to check for that, a pulse check probably isn't the best way to do that. We have things like end-tidal capnography. We have things like ultrasound. We have things like a rhythm strip. And so the American Heart Association essentially removed pulse checks from the guidelines. And this isn't a novel update. This happened in 2010. So the last time that pulse checks were recommended as part of routine AHA resuscitation in terms of BLS and ACLS was in 2005. So the knowledge translation gap here in 2021, some places are doing this, but it's still often heard, let's pause for a pulse check. Who has their hands on the carotid? Do you have your hands on the femoral? It still happens 11 years after the guidelines were updated. And you may say, okay, well, like I'm sure it's on those cards that they distribute and that you get during your ACLS training, it says so. Well, it says rhythm shockable. Is the rhythm shockable? Is the rhythm shockable? It doesn't say pause for a pulse check. It says ascertain, is the rhythm shockable or is it not? And that's because the time that it takes for us to identify a rhythm, like a perfusing rhythm or a non-perfusing rhythm or a rhythm that needs some sort of intervention, i.e. electricity, is actually quite small. So what I'm gonna do is I'm gonna put y'all to the test. And unfortunately, this can't really be interactive, but I'm gonna time you and go through. All right, what's the rhythm? I'm sure by now in the 2 seconds, y'all have all identified that this is a V-fib rhythm. What about now? Asystole, that was 3 seconds. What's the rhythm? VTAC, 2 seconds. What's the rhythm? Extra points if you say bradycardia. I don't know. If I were in a resuscitation, I'd look at this and I'd be like, that looks really the most organized rhythm I've seen during a CPR. Let's pause and see if they're perfusing with this. Let's look at their ultrasound or something like that. We are really good at rhythm assessments. This one is a little bit tricky. If you see this, it's probably a Saturday night and hopefully you're not in the emergency department. So despite guidelines, despite courses and journal articles, despite pocket cards and all of these things that are meant to translate the knowledge into practice where we deliver patient care, we just can't help ourselves and we still ask for pulse checks. We are still being told by whoever's doing the timekeeping for the code, it's time to pause for a pulse check. Despite all of these things, that knowledge translation gap persists. And so last year, I was scheduled to come and talk with y'all about this, about how digital dissemination and social media can help move forward and mitigate this knowledge translation gap, about how we can reduce the amount of time it takes to translate knowledge into practice so that our patients receive the best, most evidence-based and up-to-date care. Now, over the course of the past year, some things have changed. We have all kind of become obsessed with masks and PPE. We're sort of experts in mask fit tests. We've never paid more attention to the smells that we smell while wearing a mask. We've become experts in hopefully figuring out how to unmute ourselves and mute ourselves, how to hide our video when we're eating or drinking or doing something else during a meeting. And we've become experts in delivering clinical care and seeing patients in places that were never intended to deliver patient care. In parking lots, in parking garages, in hallways. Well, some of us were doing that before COVID anyways. But COVID happened. And along with that came this influx of information and digital dissemination. It's sort of a renewed attention and devotion to getting information from the digital platforms. Specifically, people used a lot of Twitter and Facebook in order to disseminate research and information regarding the coronavirus pandemic. And so what I'm going to focus on largely for the rest of the talk is on knowledge translation in COVID-19, because I think this represents a really unique opportunity for knowledge translation. But it was very interesting because by the nature of the disease and the pandemic, most of this did happen in digital spaces and through digital media. It's also interesting from a knowledge translation perspective because there was no time. This really was a time when we needed to mitigate that knowledge translation gap, because it wasn't like, well, you might see this patient. It was like, you have these patients in the emergency department. You've had them in your emergency departments for the past couple of weeks or months. How are you going to treat them? We're looking for therapies. There was no time to lead up and train. There's also no knowledge. We were sort of empty vessels when it comes to COVID-19, which is really kind of rare when it comes to disease processes in medicine. Most of the time, we come to a disease process and we have things that we learn when we were preparing for step 1 or step 2, when we were doing our rotations in residency, when we were practicing as emergency physicians and attendings. We have some sort of knowledge base to operate from, which can bias us and make it harder to relearn or unlearn things. But also, we just had no knowledge and we had that desperation there. It was also interesting because a lot of the traditional dissemination methods couldn't really work here for various reasons. And here I'm talking about traditional dissemination as like getting the print edition of a journal to your house. So for example, getting the New England Journal or Annals of Emergency Medicine or Academic Emergency Medicine delivered to your house. That takes time. And then you actually have to read it. And if you're busy doing back-to-back shifts and trying to manage online Zoom school, you don't have time for that. And then professional society networks, things like clinical practice guidelines. Again, typically they are based on evidence. And we didn't have any evidence when the coronavirus pandemic started. And then it takes time to formulate consensus opinions, to grade evidence quality, and then disseminate it outward. Same thing with conferences. We couldn't travel. It took us a while to figure out how to do all of this online. And even then, how do you motivate people to show up for yet another virtual meeting? And then there's emulation. So much of our clinical practice we think is based on evidence, and it's based on what we've seen people do, how we were trained to conduct care, and then how we've watched others, our peers, our colleagues, how people do things at our institutions. And then there's digital dissemination. And this is really what happened in the coronavirus pandemic. And this really took place in the coronavirus pandemic for two main reasons. So digital dissemination has a clear advantage over traditional dissemination metrics for two reasons. It's fast, like really fast. You can get information out instantaneously. You don't have to wait for a print journal. And it's accessible. So people can access it wherever they are. And digital dissemination, that's essentially what it capitalizes on, meeting people where they are. And in 2021, I mean, heck, even in like 2015 and 2013, people were on their phones. That's where people were getting information. That's where people were going. That's where people already were. So by meeting people and delivering them clinical information in the spaces that they already are, whether it's Twitter or Facebook or some other media, you're able to reach more people than if they have to wait for a journal article that they may not ever even come across. So thinking about the early coronavirus pandemic, thinking about something that saves lives, that's what we wanted. We wanted something that could save the lives of these patients because we really had nothing to offer them, especially our critically ill patients, hospitalized, those on oxygen. We didn't have anything to give them. And we were like, what therapy can we give them? And then a few months into the pandemic, something came along, steroids for those sick patients who are on oxygen. The recovery trial was published in a preprint journal on medRxiv server. And what they reported was dexamethasone was associated in these sick hospitalized patients with an absolute reduction in mortality of 2.8%. That's a number needed to treat of 35, which is actually really good. A lot of the things we do have numbers in the triple digits, if that number needed to treat to benefit actually exists. And this is interesting because this was on a preprint server. Preprints are not new. They're not novel to coronavirus, but it's a digital platform that exists for scientific work, for research and original research prior to it going to peer review. So yes, it's dangerous. It has not yet been peer reviewed, but also it gets information out there prior to it being published. It's a way to get it out there fast, nearly instantaneously with trial results. And so that's what happened. This study was published on June 22nd in the preprint server. And within 24 hours, people had published blogs and podcasts summarizing and critically appraising the article, going through the flaws associated with it, the limitations, what they thought the implications of the study might be. And this happened over blogs and podcasts. It also happened on Twitter, multiple different perspectives, not all of them agreeing, but people broke this down and pushed it out to people. And the reach within 24 hours was actually pretty impressive, especially considering that if you mentioned the word preprint to somebody in 2019, they probably wouldn't have known what you meant. And so I just want to think about the timeline here for a minute. So the article comes out June 22nd. By June 22nd, June 23rd, it's being disseminated all over social media platforms, digital forums. It did not reach press in the New England Journal online for a month. So if you think about how cases have grown across the world, that's a month of people that could be treated, lives that could be saved, but might not have been had that information waited to be released until July 17th. Because a press release is good, it's fine, but you can't really make decisions without actually seeing the methods, without actually seeing the data and going through some of the details. And that's what preprint in that digital form really allowed. So a month earlier, it allowed us to see those results and make some changes to our clinical practice. Now, if we were to rely on really traditional ways of disseminating research, the article didn't reach print until February 25th, 2020, or 2021, my bad. So it was nearly 8 months from when it was published as a preprint until it would have reached somebody who's catching up and trying to keep up to date with the literature while they're in the bathroom or flipping through it on their kitchen countertop. 8-month delay that would have existed. In digital dissemination, it's not just fast, and it's not just that it capitalizes on that need for information super quick, but it also captures on the need for information to be digestible. And this comes about in two ways. And the first way is sorting the signal from the noise. So part of the issue with medical literature is just the sheer volume of stuff out there. They've calculated that the number needed to read, the number of articles that you need to read in order to find just one article that is going to change your clinical practice is 20 to 200. I'm like a super nerd. I love to read articles. That's what I do in my free time. That's what I do for fun, is trying to find articles that may be applicable to emergency medicine or my practice or just interesting. And this is even hard. I can't even keep up to date with these numbers. But I think that in COVID-19, the number needed to read, I can't give you a number. Nobody's done that calculation yet, but I would estimate that it's well above 200. And part of that is just because of the volume of literature, but also the quality of the literature overall is typically quite low. And so just looking at the first couple months of the pandemic, publications increased in sort of an exponential fashion. So January 2020, early on in the pandemic, really sort of contained that we knew of to China, just a couple articles published in PubMed. Makes sense. It was brand new. By February, still brand new pandemic. More articles started getting published. By March 2020, 2,000 articles. And we're talking about a disease process that was like 3, maybe 4 months old at this time. April 2020, in April 2020, there were nearly 6,000 articles published. Again, triple that of the month before, and still brand new pandemic. Tons of information to try to sort through. We were thirsty for information, and apparently also very thirsty to publish information. That was just sort of the peer-reviewed literature. Looking at the preprints as well, you can see the surge here. Like, obviously, there were like very few preprints in January of 2020, which is on the far left of the screen. Moving to the end of 2020, December, on that far right of the screen, you can see over 10,000 preprints on just one type of preprint server, the medRxiv, bioRxiv collaboration, 10,000 preprints. So many of these may not end up going on to the peer review published literature, but people are still going through them. People are still calling them up. Now, thinking about making it digestible again, it has to be usable information for the clinical bedside. Not everyone is a researcher. Not everyone loves to really dig into the method section of the paper and really look at the analyses. But most of us as emergency physicians have seen a patient come in like this. They're short of breath. You hook up a pulse ox to them and you're like, well, that diagnostic conundrum is solved. I know why you're short of breath. You have no oxygen in your body. Your SATs are 45%. And very early on in the pandemic, we were told, yep, put them on some oxygen. If they need more than 6 liters or some conservative number of liters, then you need to intubate them. And this was for 2 reasons. This was for based on very small numbers of literature on SARS and the MERS virus, showing that maybe these patients failed non-invasive ventilation and ultimately ended up intubated. But these were very small numbers of patients because these did not turn into pandemics. They were relatively contained outbreaks. The other reason was concern for transmission to healthcare workers. We didn't know a lot about how it was spread, how effective our personal protective equipment were, about environmental controls and things like that, things that we could do to help mitigate transmission. So we were told to intubate these people. Well, that thinking changed as we found out that many patients, some needed to be intubated, many patients could be managed on high-flow nasal cannula or non-invasive ventilation effectively. And then also, transmission to healthcare workers didn't seem to be really a big player from the use of things like high-flow nasal cannula. And so people started breaking out this information and presenting it to clinicians in digestible ways. So, for example, everyone had their own algorithms and their own flowcharts and their own hospital protocols, but some people disseminated these online. It was a way to get that information out there quickly, but also in a succinct fashion, such that somebody could look at this, they could save it to their phone, they could pull it up and be like, so what were those recommendations? And not necessarily that they had to use this, but that it was sort of a way of thinking, a way of processing, a clinical flow algorithm for them that wasn't mirrored down with tons of text. So oftentimes we're creating protocols, it's all text, because we think that's what we want, because we have trouble not putting in references for the things that we're doing and citing studies and really getting into the technical details. Whereas what clinicians need at the bedside is something simple to follow through. But it wasn't just really the social media people that are really into infographics and graphical representations of things. Actually, journals get into this as well. Visual abstracts have become an important part of disseminating research findings across journals. Most major journals have a visual abstract component. And as a researcher, even if a journal I submit to doesn't, I will often create something that is a visual abstract. This is an example of something that they entitled a visual abstract, although you'll see it's really like a screenshot of a PowerPoint slide with just text of the results on it. But this is effective in making something digestible, because oftentimes it's like, oh, you see a paper or a link to a paper and you're like, I can't possibly read the whole thing, versus drawing somebody in with a little bit of color, breaking it up a little bit, highlighting certain things. You really draw somebody who may not be a methodologist, who may not have statistical training, who may not feel comfortable reading the paper, into some of the key highlights, such that they may be interested and they may be motivated at that point to go on and read the protocol or read the actual paper. So this has become a way of disseminating research findings, both in COVID and before COVID. And visual abstracts have actually increased the number of citations as well as article shares. So when they have tweeted out or disseminated an article in text format versus just accompanying that with a visual abstract, they found that they get 8 times more article shares and 3 times the number of reads for that article. So more people are sharing the article than are actually reading it, but still increasing the number of people that are actually going back to that article. So visual abstracts are another way for people to sort of engage and direct that research dissemination and really make it digestible and accessible as well as fast. Now, digital dissemination, it ain't all rainbows. It's not all good news. There's actually a dark side to it as well, which all of y'all are probably aware of by now. So dissemination, whether it's in the traditional form or in the digital format, it's got to be reliable, or at least we hope that it is. Traditionally, when a study is completed, oftentimes they release the results, whether it's at a conference as an abstract or via a press release. This has sort of long been the practice. Now, there's a problem with this. So, for example, a study that recently came out, the Corona trial, came out with this press release. Colchicine reduces the risk of COVID-19 related complications. Positive results from the Corona trial show that colchicine is the only effective oral medication for treating non-hospitalized patients. I look at this and I'm like, this is a miracle drug. Oh my goodness, this is amazing. It's got to be great. Wow. And so looking at this press release, well, they announced that the study results have shown that colchicine reduced by 21% the risk of death or hospitalizations in patients with COVID-19 compared to placebo. And you're like, death or hospitalization? I care about that. This is great. They go on to say the result obtained for this global study population of nearly 4,500 patients approached statistical significance. Now, unless you're kind of cued in and paying attention to things, you may not realize that they're essentially saying that this was a negative trial as would traditionally be billed, i.e. they did not meet their primary outcome, that maybe a subgroup analysis or something else did it, or maybe it looked really good, but didn't quite reach that threshold that they had specified. But then in that same paragraph, they go on to say this major scientific discovery makes colchicine the world's first oral drug that could be used to treat non-hospitalized patients with COVID-19. So here you have them saying, we have a negative trial, but this is a major scientific discovery, and it's the first oral drug that can be used to be treated. So you can see how people might have been confused here, because if you're a layperson reading this, you're like, this is amazing. And if you're a researcher, a methodologist reading this, you might be like, this does sound a little bit fishy. Usually we would just talk about we wouldn't quite build the results in quite a positive way with a negative trial. Now, that's sort of an example of how traditional dissemination cannot be so reliable. Another example of that would be the retractions. We had peer-reviewed published papers in both the Lancet as well as the New England Journal of Medicine related to COVID-19 that were retracted within a short period of time after being published. They went through the peer review and editorial process. They were published, and then they had to be retracted because the data sets were faked. So traditional dissemination, traditional methods of peer review, they're not foolproof. But digital dissemination does make it a little bit tricky, because you can have these public forums and arrays in which you can have these exchanges that happen really fast. This is an example that just happened recently regarding the AstraZeneca vaccine. We've been awaiting the approval of more and more vaccines. We've been stalking their efficacy, stalking the trial results, and waiting for the press releases and knowing that they're going to apply to the FDA shortly thereafter. So recently, AstraZeneca released a press release saying they demonstrated statistically significant vaccine efficacy of 78.9% in preventing symptomatic COVID-19 and 100% efficacy in preventing severe or critical disease in hospitalized patients. However, the NIH, the NIAID, a portion of the NIH said, well, wait a minute. AstraZeneca may have included outdated information from that trial, provided an incomplete view of efficacy data. We urge that company to work with the DSMB, the Data Safety Monitoring Board, to review the efficacy data and to ensure that it's up to date. And this is all like this public exchange. This was all over NPR. It was all over CNN. It was all over all the major news networks, this public sort of passive aggressive exchange between a major pharmaceutical company and the National Institutes of Health. So AstraZeneca responded the next day saying, no, our preliminary assessment and those results were consistent with the interim analysis. We're completing validation. But this back and forth happened over a couple of days, which is great. It's great that it's sort of transparent and open and out there. But it also just demonstrates that in this rush to be fast, in this rush to get information out there really quickly, there still are unanswered questions. And that the public forum, you can do public damage to trust by putting all of this out there in a public way. So digital dissemination, just like traditional dissemination of information, we've got to build it reliably. We've got to make sure that it's accurate. And when something doesn't add up, when it doesn't stack up right, it's sort of on us to help control that narrative. And part of this is because few people are going to read the actual paper. And that sounds sad, but a lot of people have opinions on papers that they haven't even really read, or at least read in detail. One of my favorite examples from the COVID-19 pandemic comes from this one that came out fairly early, in the pandemic in the United States. COVID-19 disease. ORF8 and surface glycoprotein inhibit heme metabolism by binding to porphyrin. And you may not recognize the title, but I assure you that you have heard about this paper in some way or the other. And you're like, how are ER doctors getting a hold of this? Well, this came as a preprint on the Chem Archive server, so one of those preprint servers. It was picked up almost instantaneously and really made a big noise. And this was a tweeted out graphic that we commonly saw. And what you see here is you see part of the SARS-CoV-2 virus, and you see it interacting with the hemoglobin, specifically the beta chain. And you can see here that there's an attack pose to it. And so they're talking about the virus attacking the hemoglobin, a specific change and changing the configuration, such that people took this, and this was, by the way, a molecular docking study in which they sort of like simulated all of these things. It wasn't like a real sort of experiment. It was all sort of a virtual experiment. And they said, well, COVID-19, we think it's a hemoglobinopathy. Like, obviously, COVID-19 is not a hemoglobinopathy. We have evidence of that in clinical practice as we measure oxygen saturations and ABGs and things like that. But it kind of, people started perpetuating this narrative of COVID-19 causes a hemoglobinopathy. More science is needed for the use of hydrochloroquine in these patients. And people talked about how different therapies might be effective or not based on this study. So, well-meaning physicians who are non-experts in molecular docking or infectious diseases, and certainly we can talk about things we're not experts in, but started perpetuating this narrative that COVID-19 causes a hemoglobinopathy, and we should be treating it like we treat hemoglobinopathies. And so this is an example of how sometimes by actually not going through the paper and understanding what they did and the purpose of what they did and the implications for what someone did in a paper can have repercussions. So digital dissemination, it needs to be reliable. Few people are actually going to go through that paper and go through it and make sure that what you're saying about the paper is actually true or what somebody else is saying about paper. And then also few people can actually read the paper. Several years ago when I was a resident, we did a project and it mirrored other projects that have been done at Yale and elsewhere that looked at how well can residents understand statistics? And we found that 76.1% could interpret a p-value. A p-value, 76.1%. However, just over half could interpret a 95% confidence interval or an odds ratio. And then Kaplan-Meier analyses, which are like all the rage in COVID-19. That's what every vaccine paper has as is just a common way of looking at data with regards to COVID-19 analyses. 2.2% could interpret that. And these are smart people. These are people that have doctorates, many who also have advanced master's degrees and PHs. So if these people are really not able to understand analyses and read the paper, then a lot of us really don't stand a chance. And lay people certainly probably don't stand a chance. Now, with regards to COVID-19, it also represented an interesting form of knowledge translation because it really highlighted some of the way in which we develop our practices, which is we kind of start at the patient's bedside. We do something and we're like, oh, that worked. And we feel good about it, or we publish it. We're like, hey, look, my anecdote, I just turned it into anecdata. I submitted that case report or that case series or this retrospective study based on what we did here. And certainly there's a role for that. But that anecdata, those anecdotes, they become referred to as evidence. They form the foundation of what we do. And once we make that transition from identifying something as an anecdote or anecdata, and we turn that kind of in our minds by seeing something in peer review as evidence, that's when things start to get tricky. Now, what happened in COVID-19 is then people said, okay, we're going to do trials based on this. So if you take, for example, hydroxychloroquine, people were like, there's a mechanism here. There's something plausible here. And so people started prescribing it and filling it and rushing to take it prior to any real literature, prior to any data, just based on plausibility and maybe some anecdotes. So you can see here in this red triangle underneath there, that is the spike in filled prescriptions for hydroxychloroquine. And you can see how nicely that lines up to sort of the peak early pandemic emergency when every sort of the country was sort of uniformly, like for 2 weeks, taking it seriously. We see that rise in fills for hydroxychloroquine. That wasn't just patients with rheumatoid arthritis or lupus or things like that. This was people rushing out for SARS-CoV-2 treatment. And so what happened then is people are like, well, we'll do more and more trials of hydroxychloroquine because look, all this evidence, people are taking it and they say it works and they've seen patients do just fine with it. They've treated a lot of outpatients with it. None of those patients have gotten sick or have died. And so we see that the number of trials of hydroxychloroquine increased and increased and increased and increased. And so what happens then is once that trial data comes back, you got to go back and it has to reach the patient's bedside from whence the original evidence originally came. And so when these trials came out, they were essentially all universally disappointing when you look at the randomized trials, not the retrospective studies, not the observational studies, but the randomized trials, whether it's for prophylaxis or for treatment, hospitalized or not hospitalized patients. This is what they found. So how do you take that back and go change people's mind? What happens is you got to take that trial data, go back to the patient's bedside And here you have to unlearn, clinicians have to unlearn behavior. And even patients have to unlearn some of the expectations and evidence and ways of doing things. So COVID-19 showed us that not only was the knowledge translation motivated by no time and this sort of evolving knowledge, but also this frequent need to unlearn information, unlearn that masks don't really do anything when the lay public wears them, right? Oops, our bad. That hydroxychloroquine may be a lifesaver, that people need to be intubated early after just low flow oxygen, those sorts of things. But this happens all the time in our clinical practice, this need to unlearn. We just don't really recognize it. It's also hard, and I think unlearning is harder than learning because it's easier to stuff more information into our brains. Like, we're experts at that. That's what we've been doing since before med school, from our pre-med days, while we were trying to study for the MCATs, to the first, step 1, step 2, step 3, to actually providing clinical care. Is we're good at putting information in. But if you ask us to change the way we do something, that for us is really hard. So what I want y'all to do is just do this little exercise with me. I want you to take your hands like this and clasp them together. And I want you to look and see which thumb is on top. So for me, my right thumb is always on top. It feels natural. If I do it a million times, and without thinking about it, that's just how my hands land. Now, some people are going to be a little bit of an outlier and have your thumbs parallel. I don't know what to do with that. That's just a little weird. You're very rare. You're special. But what I want you to do is clasp your hands together. Now, I want you to go and clasp them the other way with the other finger on top. Now, when I do that, it feels really weird. And I've practiced this a bunch, but it makes the hairs on the back of my neck, my hackles stand up. It just doesn't feel right. It's kind of creepy. And if I were to go back and just clasp my hands without thinking about it, I would default to right on top. Because that is my norm. That's how I've learned to do things over the past 36 years. And that's kind of like learning. We're really good at learning. We've learned how to learn. That's what we do. But if you ask us to unlearn, we have to consciously make those changes and sort of rework our synapses, our ways of thinking about things, so that in the middle of a resuscitation, when we are at the end of a string of overnight shifts and we have a resuscitation and a STEMI and an agitated patient in crisis all at the same time, that we can still make the right, most evidence-based decision, even if it means doing something different than the way that we've done it over our past 10 or plus years in clinical practice. So that is unlearning, keeping the other hand on top, that awkwardness, the kind of weirdness and unfamiliarity associated with that. And unlearning is hard kind of because we go through this Kubler-Ross kind of stages of grief. When we're told something that we are doing clinically, or even not clinically, for example, my wife tells me that I fold our towels wrong when I hang them up and that I load the dishwasher wrong. But it's hard for me to do that because that's the way I've always folded my towels, and that's the way I've always loaded the dishwasher. So I go through shock, like, who would put the bowls on top, Brack? Like, who would do that, really? To denial, like, I'm just going to ignore that those are there. To anger, to depression, like, maybe I'm going to give up. I'm not going to load the dishwasher anymore. To finally acceptance that maybe there's another way of doing things and maybe there is a rationale to doing that. An example in COVID-19 that sort of recently came up and was very public, pulse oximeters. We've used them for a long time, and we make a lot of decisions based off the information we get from a patient's oxygen saturation. We make disposition decisions. We make therapeutic decisions. Steroids, no steroids. Are you going to get put on oxygen? Not going to get put on oxygen. Are you going to go home? Are you going to come into the hospital? Do you need an ICU consult? We make a lot of these decisions based on these things. But it turns out that multiple studies have found that pulse ox readings, even from hospital-grade pulse oximeters, are artificially high in patients with more skin pigmentation. So the level, the oxygen saturation that it's spitting out may not, if you were to draw blood gas on that patient, may not reflect that patient's true oxygen saturation. A study recently gained a lot of attention in the New England Journal that looked at thousands and thousands and thousands of paired measurements from multiple centers of ABG readings, and oxygen saturation readings. And these were mostly from sick patients, from hospitalized patients who are on supplemental oxygen. And obviously, we're getting an ABG and had a pulse ox reading within 10 minutes for some reason. But what you can see here is the blue lines, those are white patients. The red bars, those are Black patients. And anything gray below that 88% means that the ABG reading was below 88%. So you can see here, by the time you get to a pulse oximetry reading of 92%, a decent number of Black patients have occult hypoxemia. They have an oxygen saturation when you were to draw an ABG of less than 88%, which we might take relatively seriously. When you get to 91, 90, 89%, a lot of people are in the mid 80s who are Black. Certainly it trends down for white patients as well, but you can see that for across all levels, the reading is lower. And this is because the pulse ox, the devices have traditionally been trialed and tested in white patients. So you're allowed about 3 degrees of bias, but that doesn't account for bias that may be introduced as a result of pigmentation changes. So this article came out, and this isn't the first study. There have been studies like this for well over 15 years, kind of demonstrating the same idea. This is just by far the largest. But a letter to the editor just came out saying, well, you know what? It's inappropriate to call this racial bias, and we should really be careful about these study finding results, and we think that they might not be right. But the thing here is that medical devices such as pulse oximeters are blind to color and cannot exhibit such a bias. And I think when these people were responding, they were responding with some degree of denial and emotion in here, and kind of forgot that the way that pulse oximeters really work is they use color. They, in fact, use a red light. They rely on that color. And that you refer to the bias in terms of, does it read plus 3%? Does it read below 3%? That's called the bias associated with that measurement. That those are, in fact, linked, and those are ways that we use to talk about even these medical devices and how they work. So this is an example of sort of that emotional response to something that was presented as objective information, even in the New England Journal. And so unlearning is hard. We go through all of these emotions, and it's not just COVID, where it's new stuff, and there's a lot of political stuff going on, and there's just a lot of emotion overall, and we desperately want things to be over. This happened on shift recently. A colleague came up to me and said, "Westafer, you're killing me." And I said, what did I do? Like, was it a bounce back? What happened? And he said, I got a bone to pick with you. I have used lidocaine in my GI cocktails my whole career. And I just had a resident say to me, well, as you know, you can leave the lidocaine out and just give the antacid, and it's just as effective. So I've been doing this my whole career. Where does this come from? And it came from multiple randomized controlled trials, but one was just published recently. And so the first reaction was, but I've seen it work. I've given it to people and they say they feel better. So again, we rely on that power of anecdote. Unlearning is hard. We get that shock, that denial, that like, you've got to be kidding me. You're killing me. And it's driven a lot by our anecdotal experience. We're emotionally tied to our performance as clinicians, right? We want to be good at what we do. We like what we do. We feel good about it. And we see people and we see that they get better. And so we forget that is like one of the lowest forms of evidence. And that, even if our foundation is built on some retrospective or observational type of experience, that randomized controlled trials still sort of trump that because they remove some of those biases, as long as the populations and interventions are similar. The next question was, well, Westford, then what am I supposed to give to these patients? I was like, well, you give the antacid because that's what they do in the studies. But it's that idea of like, my hands are kind of tied here. The more I give, especially if it's something that they can't get over the counter, I feel good about that. A lot of unlearning is when we're asked to de-escalate our practice. We have this drive to do something that is valued more than doing nothing or to doing doing less. We want to do something. And so a lot of our emotions when it comes to unlearning a practice, it's driven by that anecdote and that desire to just do something. And it's not just in medicine. I mean, if you're thinking about just in life in general, think about when you found out Pluto was no longer a planet. Like everyone was super upset and went through the same stages of grief. They polled people over 10 years later and said, deep in your heart, is Pluto still a planet? And 90% of people were like, yep. And I can tell you, I make this mistake with my kids all the time where I'm like, and Pluto, oh yeah, it says dwarf planet. We got to make a distinction there. I still forget that. But I mean, people were angry enough to do some needlepoint about it, but went through this because when you're told that what you have believed in and what you have maybe taught or perpetuated is wrong or incorrect, we have big responses to that. So it's not just like in clinical practice, but this really does permeate a lot of what we do. And so all of this is to say that we can help mitigate these things by really engaging in and harnessing the digital narrative, whether it is other people's research or our own. And we can do this and help people unlearn and make that knowledge translation gap shorter by making it accessible, by getting results out fast in a way that's open access. So whether it's a preprint, whether it is doing a tutorial about your research, or whether it's making a graphical abstract, you can make it digestible. Maybe your talent is filtering out the signal from the noise. Well, do that. Help people find those articles that are worthwhile, or help people understand research your research in a way that makes sense and that is processable. That they won't just be like, "Oh, the method section is too long. I'm not going to understand it." We can make research digestible as well. And then also, we all have this sort of ethical obligation to ensure that the messaging is appropriate for our study. Maybe somebody is interpreting our study in a way that makes us feel good, but isn't necessarily appropriate. Maybe it's an overcall or an undercall. It's our job to make sure that that's appropriate. Or if we see something, I think that one thing that we can do to help that knowledge translation gap is, again, make sure that that messaging is appropriate. But in the end, one thing that we do have to remember is knowledge isn't everything. Just because we know that we should do something, it doesn't mean we actually do it. And part of that may be unlearning, and part of it may be laziness. Part of it may be just stress. There are lots of things that go in. And I think this happens on a regular basis. For example, they did this study where they watched people. We know hand washing saves lives. We know we should do it. We know when we should do it. We take modules on it every single year about infection control. So at a surgical conference, back when in-person conferences were a thing, they monitored how many of these surgeons washed their hands coming out of the bathroom. And what they found is that only 1 in 5 surgeons washed their hands upon exiting the bathroom, which is just like, ugh. And like, these are like surgeons, right? Their expertise is supposed to be in being clean. And it's not just surgeons, it's even hand hygiene. We know, again, we have the knowledge that hand washing is super important. Yet in emergency departments, when they looked at foaming in or foaming out or washing hands, they found that compliance was about 29% of the time. So 29% of the time when people were supposed to wash their hands or clean their hands, they did it. And then that number was actually not better after touching bodily fluids. So knowledge dissemination plays a huge role, but there's even more, and it becomes more complicated to get people changing practice. But people can't change their practice if they don't know about something. So knowledge translation, it's complex, it's hard. COVID-19 has helped us learn a lot about how people understand and process and get their information, and ways we can get information, our research, out to people to reach the bedside quickly. But it also leaves a lot of questions about how do we actually get clinicians to change that practice at the bedside, which is hopefully something that we can look forward to more in the future. Thanks, y'all, and I really appreciate the opportunity to talk with you.